A little background on data collection process. The Minnesota Department of Health and affiliates assessed healthcare provider exposures between March 6th and July 11th of 2020. The Minnesota Department of Health conducted 20-minute phone conversations with 21,406 exposed healthcare workers, of which 25% were considered high risk. High risk being, as defined by the CDC, greater than 15 minutes and within 6 feet of someone who is infected with COVID. The interviews conducted assessed exposure circumstances, protective equipment use or non-use, and proper use or failure of protective equipment utilized. It was observed through data collection that for high-risk exposures, 66% were during direct caregiving and 34% were during non-patient care interactions. Non-patient care, including but not limited to between staff members, household interactions, and social interactions. It was also observed during data collection that approximately half of high-risk exposure personnel did end up testing positive during the 2-week symptom monitoring window. A chi-square test was conducted to compare exposure circumstances and facility type to determine if there was an equal association of exposure circumstances for acute and long-term care facilities. Assuming a 5% significance level, there is not sufficient evidence to conclude that exposure circumstances and occurrences are equal between acute care and long-term care settings. The data collected illustrates that workers in acute care had a higher occurrence of wearing medical grade masks, wore eye protection more often, and had more protective equipment use, therefore more instances of protective equipment failure. It was also observed that not only did healthcare workers in long-term care facilities return to work more often after exposure, attended work with symptoms, and tested positive during symptom monitoring windows than those in acute care. Data illustrates that one positive case in long-term care led to a high-risk exposure of 3 other healthcare personnel on average, whereas acute care, one positive case led to 1 high-risk exposure on average. It was also found that the highest rate of positive infections given an exposure to a positive individual were from non-patient care related interactions, such as between staff members or outside the workplace.